Yes.
Okay, good evening, everyone. Thank you for joining for the SEEDS webinar tonight. I'm standing in just for a little while for Aneez until he arrives. I think he's caught up with something. Tonight we have a very special segment for you. Thanks to our sponsor, KARL STORZ, presenting to you topics on VATS segmentectomy. So the first speaker for tonight is Dr. Boonlawat. He has presented before, and he's an active speaker on our circuit. So he needs no further introduction. His topic for today is on ICG-guided VATS segmentectomy. So why don't you take it away, Dr. Boonlawat?
Okay, thank you. Okay. Good evening, everyone, and thank you soon for kind invitation. So I'm very happy, and I think I'm lucky that I have a second chance to share my experience on a very wonderful meeting with SEEDS tonight. And today I'm going to present about the ICG guide by VATS segmentectomy. As you may already know that the use of ICG in thoracic surgery had several ways. The first is the localization of the lung nodules, and the second is maybe the segmentectomy, and the last one with the sentinel lymph node biopsy. But today I'm gonna focus on the ICG guide VATS segmentectomy. The primary segmentectomy right now has grown in the popularity because of they become the standard of treatment in many disease situations, such as a carcinoma in situ, minimally invasive carcinoma, or become a standard treatment in peripheral small size early-stage lung cancer, especially the one that have a very limited lung function. And also for primary metastasis, especially the one that has a very central region that you don't want to do the lobectomy because you want to preserve the lung parenchyma. So you just do only segmentectomy for the patient. But anyway, the primary segmentectomy is still a very challenging operation, especially for the young surgeons who beginning to do VATS surgery. This is it's quite challenging operation because of two reasons. The first one is sometimes it's very difficult to identification of bronchovascular structures. And the second problem is to identification of an intersegmental plane. Beginning with identification of bronchovascular structures, there's a fact that for the human bronchovascular structures has a high incidence of anatomical variation, and the surgeon need the perfect understanding of the anatomical correlation between bronchovascular structure before surgery. And normally surgeons need to do more dissection to reach the target. I mean that you need a lot of dissection to read the proper bronchus or artery of that segment. Sometimes you can get confused or you can injure the structure. So normally 3D reconstruction CT scan is quite essential for accurate preoperative planning. Another problem is the identification of an intersegmental plane. There's report of several methods was described to identify the plane. But normally the conventional reinflation technique has been used. And this technique is considered for the surgeon, you need to find the segmental bronchus first, and you clamp the bronchus and you reinflate the lung. And you can see the demarcation line between inflated and deflated lung. And so this is the intersegmental plane. But this kind of technique may be difficult in some situations, such as if you do the uniportal VATS, this technique can limit your will during the operation. Or in the very severe emphysematous lung patient, the plane may be obliterated and you cannot see clearly where is the demarcation line. So let's talk about ICG or indocyanine gene. This contrasts bind tightly to the serum protein after intravenous injection. And this dye can already be seen under the infrared thoracoscopy. And this is a picture that illustrates how does it work. And for the ICG thoracoscopic unit, normally there's many brands, but I think the main feature that I think is very important for the surgeon that you need to use during the surgery is the overlay features, that they combine the picture between the normal picture that you see in the normal operation with the one that had ICG stain. In the old days, that the old version, there was no overlay features, so you have to switch the mode between ICG mode and normal mode to see where's the lesion or where's the ICG staining. But right now you have overlay mode. This is very easy for you to do the surgery with the stain in the same pictures. And for the monochromatic mode, this mode is show more contrast. You can see black and white, and you can see the demarcation line easier. And I have a video to complain more about this. And the use of ICG in segmentectomy, there are several ways. The most common way is a systemic intravenous injection of ICG. In general, normally each bronchus is accompanied by the pulmonary vein. Therefore, if the area that's supplied by the dominant artery of the segment is known, so segmentectomy can be performed safely. With the inflation technique, you need to find the bronchus, but for this technique, you need to find the segmental artery that accompany with the bronchus. If you know the artery, you can inject the ICG and you can know where is the segment that you need to resect. So this is pictures. If you occlude the target segmental artery, then you inject the ICG intravenously. So the perfused area is going to be green, right? And the non-perfused area, or the area that you need to resect or segmentect, is the non-perfused area. So the demarcation line is the intersegmental plane that you need to do the resection. So it's quite easy. So this is a first report from 2010 by Misaki, and they done the ICG segmentectomy in 8 cases of patient and with 100% successful rate. So after that, there was another report of this technique later. So another use of ICG in segmentectomy is you can done by selective transbronchial installation of ICG. During the open operation, that you snap the bronchus and you inject the ICG into the bronchus, or you can done by endobronchial scope and you do the transbronchial installation of ICG, like in these papers. They report that they use the intrabronchial installation of ICG during the operation. I don't have experience in this kind of thing, but I think it's a little bit more complicated because you need more tools to do the operations. And for the intravenous injection of the ICG, normally the dose is quite vary from the literature, starting from the very low dose of 0.1 milligram per kg up to 5 milligram per kg. And look at the table, you can see that the first report from Misaki in 2010, they used 3 milligram of kg intravenously of ICG. And after that, a lot of reports with a vary of dose, such as 0.5 or up to 5 milligram or 0.25 milligram per kg intravenously. But you can see the same result. The success rate of the operation is more than 90%. So we can conclude that the dose is not that important. The dose is not the main factors for the success of the operation. And the toxic dose ICG is usually more than 5 milligram per kg. So normally that we use is a non-toxic dose. And the timing of ICG, the first appearance of ICG normally appear after 10 seconds after injection, and they will reach the maximum intensity at 30 seconds. And the washout time is normally 3 to 4 minutes, and the report maybe up to 10 minutes for the washout time of ICG. And there's one report that is quite interesting. They found that the washout time is depend on the dose of the ICG. If you use a high dose of ICG or 3 milligram per kg, the washout time is going to be 6 minutes. But if you use low dose, such as in this paper is 0.6 milligram per kg, the washout time is around 3 minutes. So it means that if you're going to use the low dose ICG in your cases, you got to predict that the staining time is going to be shorter than the high dose. So you have to do the marking quicker than normal. But in my experience, it's okay. You have enough time to do the marking of the demarcation line. About my experience in Thammasat Hospital, normally I have a routine use of a low dose ICG, and I have a fixed dose. I don't change or depend on the patient body weight, because I think, as I already told you, that the dose is not that important. So for the easy of the use, so I just use a 7.5 or one half of a half of a vial, or 25 milligram of the ICG, or a 1 vial of ICG in every cases. It depends on what is the plan of my operation. If the plan of my operation is I'm gonna use only 1 shot of ICG, I'm gonna use 1 vial, only 1 shot, or 25 milligrams. But in the case that I plan to use the second dose, such as I plan to do 2 segments, that I need to find 2 intersegmental plane. So I know that this case I'm gonna inject twice. So I divide the half to the first dose and the other half to the second dose. So it's quite simple. And another factor that I use only low dose of ICG is the price. You can see that 1 vial of ICG in Thai is around 2,180 baht, or equal to 95 Singapore dollars, or equal to 20 US dollar. So maybe you think that it's not that expensive, but if you use a high dose, you may need up to 8 to 10 vials per case. So it's quite something, right? And in Thai, you cannot reimburse the cost of the ICG. So I stick to the cheap protocol. So I normally use only 1 vial per case of the ICG segmentectomy. And they report that the ICG has a less staining in some cases, such as severe emphysematous lung or severe anthracosis on the lung surface. The brazopan is lower than normal, so you cannot see the stain as good as normal. So this is a sample of the case. A female 50 years old with a history of lung cancer stage 1 after she got a back lobectomy with lymph node dissection 3 years ago by myself. And during the follow-up, she has a new nodule at the lingular segment of left upper lobe. The biopsy showed adenocarcinoma, PET-CT showed no metastasis. So she was scheduled for the redo VATS ringolectomy. So this is a video of the case. Luckily, in this patient, there was not much adhesion at the chest wall, but the adhesion is already happened at the hilum. And I'm doing the hilum dissection to identify the bronchovascular structures. Here's some adhesion, but it's not that much. You can perform the operation safely. The first thing that I need to find is a vein. I try to find a vein to the lingular segment. Some adhesion here. So I encircle the vein. Yeah, I identify the vein, and the vein is cut by the clip and harmonic scalpel. The vein is already cut, and then I move to the bronchus. You can see the bronchus here, and sometimes I need a sharp dissection, because for the dense adhesion, that sharp dissection is very good. And here is the bronchus of the lingular segment. So I use the stapler to cut the lingular bronchus. Okay, the bronchus is cut now, and move to the artery. This is a lingular artery. The same, and normally I use the stapler to cut the artery here. So all the bronchovascular structure is now cut. So the next is to cut the parenchyma. So now I prepare for the ICG injection, and then I inject the 25 milligram of ICG, or 1 vial of ICG. And you normally wait around 10 seconds to 20 seconds, and you will see the ICG light up very clearly here. It's light up now. You can see that it reaches a maximum intensity within maybe 1 or 2 seconds. And you can see clearly of the demarcation line in the segmental plane here, and you mark with the cauterization. So here's it's very easy. And after that, you just cut with the stapler. So I'm going to stop the video now. for the sake of time. Okay, for the next problem is can you repeat the ICG injection? Yes, the answer is yes, because it is an example of the case. This is a male 40 years old, and he has a recurrent infected bronchiectasis with abscess formation at posterior segment of left upper lobe and the superior segment of left lower lobe. So he was scheduled for VATS segment 2 and segment 6 segmentectomy. So beginning with the superior segment. So after I divide the A6, so I inject the ICG, only half dose. You can see that maybe a little bit less stain, but you can see the ICG stain. But in this case, you can see that the demarcation line was not clear. So I try to look closer, but you cannot see clearly. I'm reluctant to mark the line because it's not clearly. So I switch the mode. You can see that clearly now. The contrast is very clear. So you can see that this is a demarcation line. So right now, so I know that this is a intersegmental plane for the segment 6 and the basal segment. After I done the superior segment, I move to the posterior segment and I divide the A2 segment. And you can see that when I switch on the mode, you can see that some stain is left inside. You can see here some stain of the ICG, but it's not a problem. When you inject the second dose of ICG, you can still see the clear demarcation line here of the posterior segment of the left upper lobe. So I conclude for the benefit of ICG guide segmentectomy. The first one is they can offer more accurate and easier intersegmental plane. Because of the limitation of the conventional inflation technique in the emphysematous lung, and they cannot maintain the clear surgical field. So this is an example, another example. For the 25 years old male with a cerebral nodule at the segment 3 of the left upper lobe, and he had a very severe COPD. The preoperative FEV1 is only 41% predicted. And the biopsy turned to be adenocarcinoma. So he diagnosed with a lung cancer stage 1, but due to a limited lung function, so I just do the VATS segmentectomy for this patient. So you can see that I can identify the vein, and you can see the very emphysematous lung. And after that, after I cut the vein, I identify the B3. Here's a B3 to the anterior segment, and I cut with the stapler. So I clamp the bronchus and I test. I reinflate the lung, and you can see that you cannot see clearly. The lung is all inflated. You cannot see clearly the intersegmental plane. It's quite difficult, so I just cut it, and you know that you're going to use ICG. So next identification of an A3. This is an A3. You can cut it or you can snug it like this, and I will tell you later why I do like this. I snug the artery with a vessel loop, and then I inject injection of the ICG of a half vial, 12.5 milligram. And you can see the demarcation line very clearly here from the lingular segment and the anterior segment. And you make the mark by cautery. And then you move closer to identify the demarcation line between the apical and the anterior segment here. So it's very easy for the surgeon to identify the plane. This is another example of 68 years old. She has a lung metastasis, 2 nodules at the segment 6. So this is a segment 6 segmentectomy, and I divide the A6 as usual. And then I move to identify the bronchus. Here, this is the bronchus, the B6, and then I clamp and test with the inflation. And this is the normal finding when you do the uniportal VATS. When you inflate the lung is going to come up and obscure all the view, and you cannot. It's very difficult to find anything in this kind of situation because the segment 6 is on the posterior, so the lung is going to obscure your view. So this is a limitation of the inflation-deflation technique. But if you inject the ICG, it's very easy. This is one bar of ICG, and you can see the demarcation line between the superior segment and the basal segment here. And you just mark with the cauterization. So another benefit of ICG is the confirmation of segmental artery anatomy. So I think this one is not mentioned a lot in the literature, but I think for me it's very important. I think it's very good for the surgeon, because of in some country like in myself, in my hospital, I don't have a preoperative 3D reconstruction. So I just use a simple CT scan, and before the surgery I need to reconstruct in my head. So sometimes it's very difficult and to understand where is the segmental artery and bronchus. And in some situations like a young surgeon or inexperienced surgeon that they just begin to do segmentectomy. So about the anatomy is difficult during the operation. By use of ICGs, it's quite simple. Like this case, I do the segment 1, segmentectomy, and I make a dissection, and I think it is maybe the apical segment artery. So I just snug it and inject the ICG. And after I inject the ICG, you can see that here, perfused areas, and it's a non-perfused area. And you can clearly see that this is the wrong artery because the posterior segment is non-perfused. So I do more dissection, and you can see that this one is a posterior segment. And here is the apical segment. So I snug it again, just for the confirmation and for learning. Here you can see when I inject the ICG, you can see the demarcation line between the apical segment and the posterior segment. So right now you know where is the apical segment. So the key message for this session, ICG can improve outcome of batch segmentectomy. Normally I use a dose of 12.5 to 225 milligrams of ICG intravenously. They provide more accurate in resection and also safer in resection. You get the correct anatomy. And there's a report that if you use the ICG in the batch segmentectomy, they can shorten the duration of the operation around 20 minutes when you compare to the conventional reinflation method. Okay, thank you.
Aneez, you want to take over? Aneez, are you there? I see your name on the list. Are you
so he said in the chat box that he cannot unmute. He cannot unmute. So he wants you to take over.
Okay. So yeah. Thank you very much for the wonderful presentation, Dr. Boonlawat. It's really informative, especially in countries that doesn't have, the in ICG is really good grounding to understand the concept of having a VATS segmentectomy using ICG. We can leave the questions and to the end. Why don't we proceed on with the next presenter and the next topic, I think, on sentinel lymph node biopsy by Dr. Padungkiat. You guys will know Dr. Padungkiat very well. He just gave a talk last week as well, so he is a recurrent speaker on our circuit. And his topic for today will be on sentinel lymph node identification using ICG. Take it away, Dr. Padungkiat.
Thank you, Dr. Soon, for a very nice warm welcome presentation. I'll start my talk here. Okay. Here. Good evening, everyone. Today my topic is about the VATS, sentinel lymph node biopsy and segmentectomy. This is my disclosure. So I'll start with a history of the organ conserving surgery. And you know that there's a majority of the topics about the sentinel lymph node biopsy now is in the breast surgery, right? They've done the radical mastectomy and they reduced to the modified radical mastectomy and lumpectomy with the lymph node dissection, and they started to use a sentinel lymph node. biopsy as their standard of treatment in the early 2000s. For us as a lung surgery, we did a pneumonectomy for lung cancer treatments since 1933, and then lobectomy, 62, and sublobar resection. Dr. Ginsberg started to do it in the 1990s. But sentinel lymph node biopsy, right? So I'll start from here. So sentinel lymph node biopsy is firstly described in parotid gland surgery in the 60s, and it's popularized in melanoma, breast cancer, and head and neck carcinoma. What about in lung cancer? So this is the first report of using the intraoperative lymphatic mapping in the lung cancer. So Dr. Little used 5 cc of isosulfan blue dye. They used the thoracotomy, and the thoracotomy, the positive rate of sentinel lymph nodes was only 47%. Because in the chest, the colors of the lung and the colors of the lymph node makes it very difficult to identify using the blue dye. So, and then Dr. Lipte in 2000, next year, he used a technetium 99M sulfur colloid, and injected in 4 quadrant during the thoracotomy. And they used a gamma probe, and it had a sensor. And if the signal becomes 3 times higher than background, they said as a positive. And you can see from the table number 1 here, the identification of the sentinel lymph node is up to 82%. And the rate of positive sentinel lymph node is 32%. So you can see it's a higher positive rate using the technetium sulfur colloid. And then Dr. Nomori, he's been the one who's been very active about the sentinel lymph node. He firstly described in 2002, but his technique is a lot different than the first two publisher. So he injected a technetium colloid, the same thing, but a night before surgery, okay? And then he do a lymphoscintigraphy 5 minutes, 1 hour, 6 hour, 9 hours after the injection. And then the next day, he goes through he brought the patient to the operating theater, and then count and then find the sentinel lymph node next day. Very interesting. And he used a count on the duration of 20 seconds. If there are 10 times of count more than background, it's a positive sentinel lymph node. So the positive sentinel lymph node rate is up to 87%. And from the table number 2, that if the patient has the poorly lung function, the rate of sentinel lymph node was lower. And most of the lymph node they can detect is a lobar lymph node, level 12, 85%. And a couple of papers about the intraoperative radio-guided sentinel lymph node biopsy. They're now in the VATS era. So they have 2 groups. Group 1 is injected during the thoracotomy, and group 2, they injected using the CT guided before the VATS, and use the same criteria as the Lipte, is 3 times over background, like this, how they injected. And the sentinel detection rate is very, very high in this paper, 96%. There were no false positive, and the rate of metastasis of that sentinel lymph node is 28%. And there was some skipped sentinel lymph node metastasis to the subcarina and pulmonary ligament, about 28%. And And Dr. Nomori, 5 years later, he presented a paper of how is their techniques being done with the segmentectomy. And if the frozen section was positive, they'll do the mediastinal lymph node dissection. If the frozen section of that sentinel lymph node was negative, they'll evaluate more in mediastinal lymph node. And if the mediastinal lymph node also negative, so they avoid the mediastinal lymph node dissection. In Japan, it's very interesting because you know Japan does a lot of their lymph node dissection is very it is very thoroughly. And he published a paper in the next paper in 2007. He used a sentinel lymph node as a navigation of the segmentectomy in clinical stage 1A non-small cell lung cancer. So he used the group of clinical T1N0 patients and a little far away from the pulmonary vein, because if the mass is too close to pulmonary vein, when you inject the agent, it might drain into the pulmonary vein too quickly, so the lymph node, the number. This is the characteristic of the patients on table 3. And even more interesting that the group of non-identifiable sentinel lymph node had more lymph nodes submitted. So the data is quite reassuring that if it is negative, it's truly negative. And their primary endpoint is if the sentinel lymph node can diagnose a pathological end during the segmentectomy, and to look at survival and local recurrence too. So in the data, there are 3 patients that they need to convert to major resection because of the positive sentinel lymph node. And here you look at the data. So now, interesting that the rate of the N1 positive sentinel lymph node moved to higher to the segmental lymph node, because now what they did is a little bit different than the previous one. They did a segmentectomy, so they can even dissect even more into the segment. So the rate is higher, and you can see that the sentinel lymph node in mediastinum in the left upper lobe has the highest rate of positive. So there were some talks that the AP window lymph node is not as truly N2, they would say like this, N2.5, right? Because you can look at the N1.5. You can look at this data that sometimes the spread of the lymph node into the AP window of the left upper lobe mass is higher than the other lobes. And the rate of positive sentinel lymph node it's in the table 6. So the challenging of early use of sentinel lymph node is firstly in the blue dye, the low positive rate due to low signal to background ratio because of intrathoracic dark lymph node. For the technetium, colloid, they indeed had a higher positive sentinel lymph node, but technically challenging, right? You had to use a technetium with the radioisotope involvement, and you have to have the receptor, and the cost is higher. And this the table summarizes the successful rate of the sentinel lymph node. So what are the other what is the other options that can be used? And this is the Dr. Yolanda Colson. She presented in 2009, the use of near-infrared contrast agent. I would explain a little bit about the NIR contrast agent. There were two types. First is heptamentin cyanide fluorophores, or what we're using right now, the indocyanine green. The other thing is a quantum dot. It's a metal substance that is not very proper to use in human body. So we mainly use the ICT, and it's been approved by the FDA since 1958. And initially they were used for cardiac output and hepatic function measurement. And look at this graph here. This is the absorption factor of the major compounds of human body. And you can see from 700 to 900 nanometer wavelengths. This is the lowest point of all major substance, the oxyhemoglobin, lipid, and water. So it's very useful to use the near-infrared contrast agent to make the most demarcation line, like Dr. Boonlawat just told us. But the problem of the ICT is that it is hydrophobic. So it's rapidly transported out of the sentinel lymph node. So Dr. Colson, he combined the ICT with the human serum albumin. So when it binds together, it's transported out of the lymph nodes slowly. So it improves the sentinel lymph node mapping. So this is a summary of the advantages of the near-infrared fluorescence in vivo imaging. It has low autofluorescence, meaning that from our human body, it reflects the light the least. And they improve the tissue depth penetration, non-radioactive, very important. It's non-invasive and relatively inexpensive compared to radioisotope. And its possibilities, you can move to any OR with that. This is the picture that he initially injected the ICT into the lung, and you can see the line of the lymphatic flow into the lymph node. And 2017, she published her first paper of the novel technique of the use and targeted lymphatic mapping. The patient group was stage 1 non-small cell lung cancer. The number is 22 lesions about this big, and they used the END guided injection. ENB from electromagnetic navigation bronchoscopy to confirm the location of the tumor. And this is how it looks from the VATS view, the sentinel lymph node. So go through the ENB to the target and mark it and went into VATS. And this is how it looks, that the tattoo the nodule, and you can see the sentinel lymph node lighting up. So this technique resulting in the 80% of the sentinel lymph node detection rate, and all were 100% sensitive and specific for nodal status without any false negative. So very interesting. And next year, she published a paper of the long-term outcomes of the NIR, they do analysis retrospectively of the prospective and other trials of she was doing, and use the SRN detection rate recurrence and disease-free survival and overall survival as a primary endpoint. And the figure here shows the data of the patient. I'll show what is more interesting. So the mean ICT dose it is somewhat important in the sentinel positive and negative group. So if you injected more to the primary lesion in this paper, you can see more the sentinel lymph node. And but it's somewhat the data is somewhat not very thorough, because they do a lot of VATS resections. As you know, VATS resections, we cannot see the lobar or the segmental interlobar lymph node well. A little bit more. Okay, and the number of lymph nodes sampled, it's in sentinel group, it's 10, it's non-sentinel group, it's 15, and staging is 3/5, it's not significant. And the outcome of the pathologic node positive 3-year survival, overall survival, and disease-free survival is not significantly different. But in the pathologic node negative, the overall survival, it's significant, statistically different in those groups. But when you look into the data, the number of lymph node sample, it's pretty small. So it's I think they need more data about this. If you do more lymph node sample, you might have more significant or some different data. This is the curve showing that in the sentinel lymph node negative group, the survival is different. So what is special about the Novena, the new version of the STORZ near-infrared camera, is that they have the 4K and 3D. So you can see the picture from Dr. Boonlawat just shows very clear, and they can do overlying mode, and they can do a monochromatic mode under 4K. So the picture was very. I'll have some picture about the segmentectomy a little bit to show you too. And it's not very relevant to the sentinel lymph node, but very interesting that I want to share this paper. I think all of you know about this. Dr. Gail Dowling, she compared lymph node sampling and lymphadenectomy and show no difference in survival. But the way that they did a interoperative sampling is that they froze every lymph node and station that they did. So if anyone wants to do the lymph node sampling, you should also do the frozen section and make sure it were all negative. And I combine all of this technique, and I use the frozen section as in her paper. So how I do it? So I do in 2 situations. I do in the segmentectomy to determine if more resection is needed. So if the frozen section is positive, I would do lobectomy. And second, I will do it in the metastatectomy. So I do it to avoid. So Dr. Boonlawat gave us a talk weeks ago that lymph node status is can give us some prognosis of the patient. But metastatectomy, we don't want to do a full mediastinal lymph node, right, to avoid the complications of the dissection. So if we can do the sentinel lymph node, this is my idea, we can avoid the full mediastinal lymph node dissection. And for the obvious lesion that we can palpate, you can see through the pleura, I'll do the direct injection. If the lesion is a GGO or very deep, I'll do the ENB with ejection, and then you do the uniportal VATS to look into the patient. So I'll have some example to show you. This is the first case. 65-year-old gentleman has right middle lobe nodule here, a biopsy proven adenocarcinoma, and the GGO and very small portion of solid parts right in the posterior segment of the right upper lobe. And this is a PET CT. It's very mild uptake on the right middle lobe nodule, and the right upper lobe is no uptake at all. So the perfect position to do the segmentectomy of the posterior segment. So this is how I did it. So for the right middle lobe, right middle lobe, I'll go straight with the lobectomy. So I'll inject. I injected the ICG to the posterior segment of the right upper lobe first. This is how it shows initially. I injected 1 milligram. And then I completed the right middle lobectomy. And then this is about an hour apart from the first injection. You can see the signal it's spreading out from the primary point. So I tried to look into the hyaline node first, and I didn't see anything at all. So, and then I looked into the around the posterior segmental bronchus, and you can see that it is a drainage through the lymph node here. So I did a biopsy of this lymph node. You can see there's a signal of the ICG lighting up here, and sent it for frozen section, and it was negative. So I did a posterior basilar segmentectomy. And this is the final operation, lobectomy, posterior segment, and the lymph node were all negative. This is a second case. 60-year-old gentleman, right lower lobe nodule, 1 centimeter, adenocarcinoma. There were no hyaline mediastinal lymph node enlargement. So I did the same thing, 2 cc of the ICG and direct injection. And after 28 minutes of the section, the sentinel lymph node found here at the level 13, and I biopsied it and sent for frozen section. And it was negative for malignancy here. You can see some signal up here. And then it came back was negative. And you can see the line of the lymph node, that it drains down into the hyaline mediastinum. This is the line of the lymph node. With I can tell you that the new version of this camera really improved the visualization. And this is also the lymphatic line over the bronchus here and drain into the mediastinum. And so after I cut the basilar bronchovascular structure, as with Dr. Boonlawat, I inject the ICG, have 12.5 milligram. And I did a demarcation line. You can see it's very nice visualization of the segment. And I did the segmentectomy. So this is the completion of the operation. The patient was discharged on port-op trip day 2. Interestingly, in this case, the pathology report, it came back as a positive micrometastasis, 0.9 millimeter. And the rest of the 5 level 1 lymph nodes were all negative. And the tumor itself, it's 1.5 centimeter, has visual pro invasion, good stable margin. And also the mediastinal lymph node, they were micrometastatic, 0.6 millimeter at the level 7. And the rest of the 12 mediastinal lymph nodes were negative too. Interesting. And this is another case of a 35-year-old lady with multiple metastasis of rectal cancer to bilateral lung. They wanted the tissue for the next generation sequencing, but with the attempts of the CT biopsy, the tissue was inadequate. So she was sent to me for the tissue sampling. So I did more with the sentinel lymph node. I injected here and drain into the inferior ligament station, biopsy it out, and it came back negative. Another case that very peripheral lesion has a lobectomy done. I had the lobectomy done on the right upper lobe already and had progressive left lower lobe nodule. This case I did the ENB to mark the lesion. This is how it looks. This is the old version of the camera though. So in conclusion, the near infrared combined with the ICG is a safe and effective method to identify sentinel lymph node and performing the segmentectomy. And the sentinel lymph node navigation segmentectomy may omit the need of systematic lymph node dissection, especially in the patients who have multiple GGO, which may require subsequent anatomical resection in the future, but in the randomized controlled trials are required in the future. Thank you.
Hi, everybody. I have a problem. I can either talk or see, so I will do the talking part soon. Thanks for covering. Good evening, everyone. Thanks, Boonlawat, and thanks, Padungkiat. Excellent presentations. There are a few questions which have come in, and some have been answered online. There's a question to be followed up for Boonlawat. Professor Zhao asks, can you explain to me the pros and cons of ICG segmentectomy for benign? Is there any difference how you treat between benign and malignant?
I think it's all the same because the principle of ICG for the segmentectomy is already defined the plane. So for benign and malignant lesion, it's going to be the same. But in terms of define the plane, but for the margin is different, right? But in terms of finding the plane of segment, it's the same. So I think there's no pros and cons for ICG guide segmentectomy.
I wanted to ask you a question. So some people have tried using bronchoscopic ICG to define a segment.
Yes.
Do you have any experience in that modality?
Sorry, I don't have, but I see some literature that I mentioned in the speak.
Yeah.
That they use the endobronchial installation of ICG, and it's going to be very good. You can see it light up of the. It's like a positive staining. The segment that you want to resect is positive. It's a greening, and it tend to be longer. It stain longer than the systemic injection. But you need the endobronchial manipulation during the operation. So for me, I think it's a little bit complicated for my institute to conduct this kind of thing.
Yeah, absolutely. What do you have any experience with albumin tagged ICG? I know you mentioned it in your talk, but do you think it's a bit more expensive? And do you reduce the dosage if you're adding albumin tagged ICG?
I use only the ICG that I mentioned in the talk, not albumin tags. No.
Okay. Question to you, Padungkiat. You know, there are papers out which came early where they, from Texas Heart, where they use sentinel lymph node biopsy using Geiger counter. And that was, it did show some difference, but it was too cumbersome. Do you routinely inject only for solid nodules to track your SLN, or do you use even for softer lesions? Have you ever tried it for anything like a GGO, mixed GGO?
Yes, I did with the GGO, but the technique has to be the ENB because you cannot see the lesion very well. But I think that the drainage of the lymphatic flow is just the same. It is the not go because we do not really inject into the tumor. Itself. We inject it peritumoral area.
Yep. People who do lymphadenectomy will argue that all the lymph nodes are coming out anyway. So do we really need to tag an SLN? So what do you think is your point to say SLN must be a tag point?
Well, I think you know with the low dose screening program, you can see lots and lots of GGO, and especially in the Asian population, you will see some patients who initially presenting with 3 GGOs, 4 GGOs, sometimes in the same size and different size. So you do a lobectomy or segmentectomy in the first lesion. You may need to come back to do another anatomical resection, right? So if in the field, if you do all the lymphadenectomy in the first attempt, you have no answer for the second attempt. That's why the Sentinel node, the guided segmentectomy comes out. But it fell off of the fashion because the technicality was difficult.
Yeah.
Dr. Nomori, he used a technetium, right? But with the ICG, things are different. So you can reset less node with the same result. But we'll need a randomized trial, of course.
Absolutely. I also agree. I also agree that the optics have improved with the new KARL STORZ kind of equipment, and it makes vision and viewing much better. Question to both of you: in your practice, have you faced adverse reactions after using ICG? Whoever wants to go first can go.
Okay, me first. I never experienced any adverse reaction, but they said in the literature that maybe have some allergic reaction, but personally don't have any experience. Most of the patient fine, no problem.
Same, never.
Yeah, me too. I also never experienced. I agree with both of you. I think it's pretty safe, and we've never experienced anything. And for those of you, if you listened, please closely follow the guideline doses given by Boonlawat. I think they're extremely important for you to get good reactions. Okay, guys, thank you very much. It has been awesome. Great discussion, good presentation. Okay. And everybody from ASEAN, whoever's listening, have a good night and stay safe and COVID-free. Okay. Bye-bye, guys.
Bye.
Bye.
Bye.